Hi, good morning to everyone, and thank you so much for coming to our webinar. This is Dr. Albert Domingo from the WHO Philippines Country Office. With me on our webinar for
Hi, good
today
morning to everyone, and thank you so
is
much for
our
coming to our
speakers.
webinar. This is
Stand by.
Dr.
We're having
Albert Domingo
technical
from the
issues.
WHO Philippines.
There. All right. So again, as I was saying, we have with us this morning Dr. Gary Kuniyoshi, Sophie Dennis rather, and Dr. James Heffelfinger, all specialists based at the regional office for the Western Pacific in Manila. We are all broadcasting from Manila, and we are glad to have you with us. Just to let my colleagues know, there are now 88 attendees and climbing. So this broadcast will also be available on YouTube to those who were not able to register within the 500 mark. And what we're going to do is there will be 30 minutes of a presentation by our speakers, after which we transition to a question and answer portion. For that portion, there will be a feature within the Zoom interface to put your questions. You can also upvote any questions that you think are relevant to you, and we'll take it from there. So over to you, Gary.
Thank you, Albert. I'm very excited to talk to you today in this webinar because we at WHO get to dialogue with you, the future frontline clinicians. And I'm speaking about the junior clinicians, interns, students going through clerkships, non-specialists, you who are preparing to be frontline healthcare workers or assisting specialists in treating severe and critically ill COVID-19 patients. What we're going to be going over are the WHO guidances. There is an open WHO clinical care for severe acute respiratory infection course that's on the open WHO website. There's also an interim guidance for clinical management of severe acute respiratory infections when COVID-19 disease is suspected. And there's a new toolkit that has come out in the last week called Clinical Care for SARI Toolkit. It has checklists, algorithms, guides, and memory tools in it. Today's topic is going to be oxygen therapy. So the learning objectives for today's lecture is going to be first, understanding the importance of oxygen therapy. Second, the indications for oxygen, how to initiate oxygen therapy, the measuring oxygen levels, and how to titrate oxygen therapy. So let's start with defining what we mean by this word SARI, severe acute respiratory infections. So an acute respiratory infection is simply when you have cough, fever, sputum production, something indicating either upper or lower respiratory tract infection, and it's acute, it's within the last 10 days. To designate what severe means, essentially it's if you're sick enough to require hospitalization, then that would be considered a severe infection. So SARI is when you either have fever, cough, sputum production within the last 10 days and requires hospitalization. So COVID-19 has a broad clinical spectrum of disease. It's true that most will have either mild or moderate disease, but around 20% will have severe disease, including pneumonia and sepsis. And about 1/4 of this 20% that has severe disease will become critically ill, progressing to acute respiratory failure and some requiring mechanical ventilation. One of the studies concerning oxygen requirement in COVID-19 patients comes from China. This is a study from Guan et al. And they looked at over 1,000 patients, and of those that were hospitalized, 41% required oxygen. Those that presented with severe disease, 70% required oxygen supplementation. So oxygen therapy is very important. hypoxemia or low blood oxygen levels is a life-threatening condition, and the treatment includes oxygen therapy. Oxygen is considered a WHO essential medicine. Oxygen therapy is proven to be both cost-effective and it saves lives. So what are the indications for oxygen? So in the hospital setting, you give oxygen immediately to patients that present with the following. If they have an acute respiratory infection and they have signs of severe illness, and these signs can include severe respiratory distress, altered mental status, or sepsis with hyperperfusion or shock. And then also patients that are hypoxemic or demonstrate hypoxemia by a measurement of an SpO2 of less than 90% by pulse oximetry. So do not delay administration of oxygen when caring for severe or critically ill patients. We'll go over a little more on the definition of severe and critically ill. So how much oxygen should you start with? So in adults, and in this series, we will be primarily covering the care of adult patients due to the context of COVID-19 infection. The care of children is covered in the guidance, and it's available for your review. But for this series that we will be doing for the next week, we will cover primarily care of the adult patient. In adults, start oxygen at 5 liters per minute by nasal cannula. If they present in a critical state, if they're critically ill, then consider starting at a much higher flow rate. That is 10 to 15 liters per minute using either a face mask or a face mask with a reservoir bag, if that's available. In children, start nasal cannula at 1 to 2 liters or half a liter a minute in young infants. Oxygen therapy is safe in newborn babies and neonates that are proven to be hypoxic. So once again, if the patient is critically ill, then you would start at a higher flow rate. And the higher flow rate is either 10 to 15 liters per minute, either a face mask or a face mask with a reservoir bag. For the definition of a critically ill patient, you can consider any patient that has any of the what are called A, B, C, D problems. So A is airway. They present with an acute airway problem such as stridor. Or breathing. They present with severe respiratory distress. C, circulation problem such as shock. And D, a major disability problem such as if they present unconscious. These patients should be started on a higher flow rate, 10 to 15 liters per minute, until you can check an oxygen saturation. So it is important to check the oxygen saturation, also called the SpO2 level, immediately. And in some patients, you may even need to consider checking arterial blood gas or ABG. It's important to check the oxygen saturation level because clinical signs are not reliable indicators of hypoxemia. You cannot tell what the oxygen level is by a clinical exam. Pulse oximeters should be available in all the care settings in which severe patients can present. This includes pre-hospital areas, emergency rooms, wards, and of course the ICU. So pulse oximetry can also be used as a triage tool in areas that are going to be doing screening. So pulse oximetry use at various triage points. Okay, this is the West Pacific algorithm for COVID-19 referral and triage for resource limited settings during community transmission. I show this because it shows how that among the signs and symptoms of severe illness that you are screening for, it does include SpO2 level. So an SpO2 level of less than 94% would be a signal that the patient needs to be referred on to the next level, which is usually a tertiary facility. So measure blood oxygen levels in all your patients with severe acute respiratory infection, and monitor patients that are receiving oxygen with SpO2 readings. So SpO2 is easily measured by the pulse oximeter and measures the oxygen saturation of the hemoglobin. Okay, remember, most oxygen is bound to hemoglobin in the blood. There is only a very small amount of oxygen in the blood that is dissolved. A PO2 is a measurement of the arterial blood gas partial pressure. This measures both the bound and dissolved oxygen contributions. But remember, only a small amount of the oxygen in the blood is dissolved. Most is bound to hemoglobin. So checking an SpO2, if you're getting a good reading, is an accurate measurement of the oxygen saturation of the hemoglobin. So there are various types of pulse oximeters. This shows some examples. The benefits of pulse oximetry are that it measures SpO2 accurately, and it is very easy to use, and it is very quick to use. There are some limitations, however. The limitations include, it does require a pulsatile signal, and can be challenging to get a good pulsatile signal with patients that are moving, or if they have poor perfusion, which is very common in critically ill patients. Also, it does not measure markers of ventilation, and these markers are the pH or PCO2. And these markers of ventilation can be abnormal frequently in patients with severe pneumonia. So consider measuring an ABG, or arterial blood gas, in patients with these. And they include, if you have a patient that's severely hypoxemic, if they have a risk for hypercapnia, and a good example is a patient with chronic obstructive pulmonary disease. If the patient's demonstrating very poor perfusion states, this can make the SpO2 reading unreliable. And this is shock. Patient has a lot of shock and say they're mottled, very poor perfusion, you may get an inaccurate reading. Then there's patients at risk for severe metabolic problems, such as acidosis, such as we see in DKA patients. You could consider getting an ABG in these patients. So the benefits of getting an ABG is that it measures both pH and partial pressure of carbon dioxide, in addition to the PO2. Some analyzers are also able to measure other key serum values, such as lactate, hemoglobin, and electrolytes, such as sodium, potassium. The main limitation of an arterial blood gas is that it requires an arterial puncture. You have to put it in a heparinized syringe, and you generally have to transport it on ice. Otherwise, you can get some abnormal readings. And then, of course, you need a blood gas analyzer. However, there are some point of care analyzers that are available that you can use at the bedside. So how do you titrate oxygen? So you should titrate oxygen to target SpO2 of greater or equal to 90% in everybody. This is adults and children. Specifically for pregnant patients, you should target between 92 and 95%. And this is per the WHO District Clinician Manual. In patients with signs of either organ failure, or they have any of those A, B, C, D signs that we talked about, airway, breathing, circulation, disability problems, those patients, you should target a higher saturation of greater or equal to 94%. Although other organizations may target higher saturation levels than this, it is widely accepted that a saturation level of 90% in a non-critically ill patient is sufficient to deliver oxygen to tissues. So when you're using higher flows to reach a target SpO2, you need to switch to the appropriate delivery device. So there are three types of devices. The first is a nasal cannula, for which you can get flows of between 1 to 5 liters per minute. Next, you should escalate up to using a simple mask, simple face mask, for flows between 6 to 10 liters per minute. And then when you're using very high flows, you should use a face mask with a reservoir bag. And that's when you're using 10 to 15 liters per minute. For each liter that you increase the oxygen level, the teaching is that you have about 4% of oxygen or FiO2 increase. So for room air, which is about 21%, each 1 liter per minute that you add, then there's an additional 4% or 0.4 increase in the FiO2. So a key difference between the two masks, the simple mask and the mask with reservoir bag, is the rebreathing of oxygen. So with a reservoir bag, you're able to take in 100% oxygen instead of the what's called entrained air from the environment, which is only 21%. However, if the bag is not full of oxygen, then the patient is essentially going to be breathing or entraining room air, just like a simple mask. So it's important to look at that reservoir bag and make sure that it's full of oxygen. Also, there is a risk if you do not have the bag that's functioning. There's a risk for rebreathing carbon dioxide, and that can be dangerous in some patients. So it is safe to wean oxygen in stable patients that demonstrate satisfactory oxygenation. Remember, the target is to keep all patients above 90%, pregnant patients between 92 and 95. If they demonstrate organ failure or they have some critical signs, such as airway, breathing, circulatory, or major disability signs, we keep those patients at or above 94%. So if you have a patient that's requiring escalating levels of oxygen therapy, the recommendation is to be systematic in your approach to determining why this is happening. In your toolkit, there is a checklist to troubleshoot warning signs when you're delivering oxygen therapy. This includes things such as checking your pulse oximeter, making sure that it's placed on the patient correctly, considering using another pulse oximeter if it's malfunctioning, checking your oxygen source to make sure your cylinder is full or that your concentrator is actually on, checking your tubing and your mask, such as making sure your reservoir bag is full and making sure that there's no tube kinks. You should also question whether or not there's an alternate diagnosis. So the patients that you're going to be dealing with are going to be presenting with upper and lower respiratory tract infections and pneumonia, but is this progressing to what's known as ARDS, or are they demonstrating heart failure from too much fluid? Also, is other treatments that you are administering, such as medications, could they have an allergic reaction to medications? So there's a checklist on how to troubleshoot and manage patients with respiratory distress, hypoxemia, despite using high flow oxygen. So you use this if the patient has respiratory distress and or hypoxemia and the numbers are staying low. or if the patient's mental status deteriorates despite a saturation of greater than 90%. So in general, higher flows of oxygen are meant to give higher oxygen concentration. And this higher oxygen concentration is what's known as an FiO2, or fractional of the inspired oxygen. But the system is not perfect because the patient can also breathe in air from the environment, and this dilutes the oxygen, especially in the patients that are severely tachypnic, breathing very fast, if their minute ventilation is very high. Thus, the values of the flow to FiO2 are just estimates. So the diagnosis of what's known as hypoxemic respiratory failure should be suspected whenever your patient presents with a rapid progression of severe respiratory distress. Signs of respiratory distress include things like tachypnea, use of accessory muscles, the inability to speak more than a few words at a time. So again, these patients should immediately be treated with oxygen. So when the respiratory system fails to provide sufficient oxygen to meet cellular needs, this is what is known as hypoxemic respiratory failure. This is when the SpO2 remains less than 90% while the patient is receiving adequate supplemental high flow oxygen, usually via a mask with a reservoir bag. These patients have developed hypoxemic respiratory failure. So this is one other option that may be available in some locations. It's called a high flow oxygen system. It's also called a high flow nasal cannula, or also a heated high flow nasal cannula. What this machine does, it infuses both humidity and heat, and also a much increased flow. So the oxygen from the wall or tank is humidified and goes into this machine and is pushed out at a very high flow rate. This does many good things for the patient and can improve oxygen delivery. So the heated and humidified air is much more comfortable for the patient, prevents dryness. The high flow essentially creates a reservoir or a sink of oxygen within the patient. And this has a lot of improvements. It improves what's known as FRC, or functional residual capacity, in the patient. It decreases what's known as dead space, which is areas of the lung that are not getting adequate perfusion, and also gives a little bit of what's known as PEEP, or positive end expiratory pressure, to the patient. So there's many good things. So this device is only for selected patients though. They should be awake and cooperative, and also hemodynamically stable. And these patients should be without the urgent need for intubation, and you should monitor them closely for the need of intubation. Another caution is that this device can generate aerosols. So when this device is used, then airborne precautions must be used, or it's recommended to be used. Airborne precautions include things such as performing within a negative pressure room and wearing PPE, which includes a particulate mask, or N95. So these patients that are presented to the hospital, there will be a significant burden of patients with severe hypoxemia, and they will need large amounts of oxygen. So be an advocate for oxygen systems in all hospitals. Your hospital may already have a well-functioning oxygen system, or they may be in the midst of developing or increasing these systems. However, there are many places around the world where effective oxygen systems are lacking. These demonstrate some of the various types of oxygen systems that may be in hospitals. They may have an oxygen cylinder system or a liquid oxygen system, or they may have an oxygen plant on site. So we're going to go over some oxygen and infection prevention and control issues. So you should always ensure that there's single patient use of oxygen devices such as nasal prongs, simple face mask, and masks with reservoir bag. This will prevent nosocomial infections or hospital-acquired infections. Also, humidification is not considered necessary if you're using lower flows and it's for less than 24 hours. Generally, for this amount of time and at these flows, the oropharynx and nasopharynx provide sufficient humidity. Further, what's known as bubble bottles. These are bottles containing non-sterile water should be avoided. Also because of the risk of infection and causing nosocomial or hospital-acquired infections. There are numerous respiratory care procedures that are either proven or may carry an increased risk for disease transmission. So all these types of procedures involve oxygen. So endotracheal intubation, bronchoscopy, performing non-invasive positive pressure ventilation, resuscitation with CPR, bag mask ventilation, administering nebulized medications, and delivering high flow oxygen therapy. These all can be aerosol generated procedures. For these procedures, airborne precautions should be taken. So ideally, it should be in a negative pressure room, and the healthcare worker should have on PPE, including a particulate respirator, which is an N95 mask. So in summary, give oxygen immediately to your patients with severe acute respiratory infection. So those are patients that have severe respiratory distress, shock, or hypoxemia, which is a saturation less than 90. So in adults, we generally start with 5 liters per minute. Unless they are critical, then you can consider starting at 10 to 15 liters per minute. And you should immediately measure an SpO2 because the clinical signs of hypoxemia are unreliable. So you titrate everyone to greater than 90%, or in 92 to 95% in pregnant females, using the appropriate delivery device for flow rate. If they have critical signs or they demonstrate organ failure, then you keep at or above 94%. Pulse oximeters should be available in all the areas that deliver emergency oxygen. And then a pulse oximeter is a device that is quick, easy, and reliable, but does have some limitations. There are some newer devices, such as high flow oxygen systems, that you can use in select cases of non-hypercapnic hypoxemic respiratory failure. So these are slides that are generated from the Open WHO course that is the clinical care for severe acute respiratory infections. In this series, we're going to be covering oxygen. Next, we'll be covering sepsis and septic shock, antimicrobials, respiratory failure and ARDS, and then ethical considerations. There are several other modules that you can access also that they don't have voiceover, but you can access them from the Open WHO website. So this is our schedule for the next week. and some useful resources on the bottom. This is the toolkit and also the guidance, the clinical management of severe acute respiratory infection when COVID-19 is suspected. Thank you.
Thanks, Gary. So just an update, we have 131 attendees on Zoom, and then over in the YouTube channel, there are around 190. So this is how we're gonna do it. So for those of us who are on Zoom, you can use the Q&A button. I think it's at the bottom. Or if the Q&A button doesn't work, we recommend that you use it because the other participants might want to upvote. So if there is a question that looks interesting that someone has already asked, just upvote or click on that and give it like a thumbs up or a like, and it will pop up more on our list. For those on YouTube, you can also do comments on the YouTube channel. I'll also be monitoring that. And going back to those on Zoom, if your question doesn't go into the Q&A, you can always type it into the chat box and we'll be able to pick it up. So maybe just to warm things up, there's already a question from John Michael Bernardo to any of the panelists. And the question is there a required duration of time of achieving the required O2 saturation, SpO2, before we can wean a patient from oxygen therapy? Or do we immediately remove oxygen source upon reaching the right O2 saturation?
So you can immediately titrate the oxygen to the SpO2 level. If there's a question whether or not the SpO2 level is accurate, that's when you should consider getting arterial blood gas. But the SpO2 level is accurate. So you can titrate, keep everybody above 90%, and if they're critical, then at or above 94%.
Right, so it's really about titrating based on the SpO2. And besides, it might take a while before arterial blood gas results come back in. So do we have questions from the audience? Any, both on YouTube or in Zoom? Here we go from Samuel Ong. Thank you very much for the lecture. Is there a recommended target upper limit of SpO2, like say 96 to 98% for patients receiving oxygen therapy? Some studies have shown that the higher SpO2 can actually increase mortality, presumably due to free radical formation. What do you think about this, Gary, Sophie, and James?
So you're exactly right. The current WHO guidance has a lower limit. There is a revision that's coming in the next week. Currently on the WHO guidance, it does not speak to an upper limit. But you are right. There are other organizations that are actually referred to in the WHO guidance that does recommend an upper limit. I agree with you. There's some literature that does support that upper limit. However, the WHO guidance currently does not speak to that specifically.
This is James. I think one of the things I would say is that you know, unless there's a good reason, and maybe there could be a reason for having a higher SpO2, you know, than 94, 95, depending on the patient. But is there a reason, you know, but in general, maybe there wouldn't be. And one issue that has come up in a number of countries, and it could come up in the Philippines, is supply of oxygen. And so if you're using, if you're oxygenating at a level higher than you need to, that may be a resource that could have been used elsewhere. And then the last thing I was going to mention, and I'm sure Gary can speak more about it because it's been a while since I've thought about it, but yes, at high SpO2 or high oxygenation levels, there can be a number of issues. And I think it's free radical and other issues that can be detrimental. But I think those accrue a little bit over time. So if it's a 10-minute, half-hour, 2-hour, maybe not an issue, but I think that's more in the intermediate longer term, but Gary could speak to that. Over.
Anything to add, Gary?
Yes, no, I agree with everything you said, James. Um, my guess is that there will be a guidance revision, and because many of the other societies are recommending an upper limit, and there is literature to back that up. There are only very few cases that I can think of where you would really want to target a high saturation, and that is people such as carbon monoxide poisoning. But those cases are quite rare. And so, and then your point about the conservation of oxygen, I think is very good. We're finding places where oxygen systems are failing. So conserving oxygen would be a very important issue.
Right, thanks for that, Gary. So here's another question. For those with shortness of breath, non-asthmatic, aside for oxygen therapy, is it advisable to give salbutamol or another short-acting beta agonist nebulization?
So the guidance is not going to speak specifically to certain clinical conditions such as that. But I think, yes, you have to give medications to treat what the underlying cause is that's causing the either the shortness of breath or the hypoxemia. And that would include giving medications such as that. The guidance that we're talking about is going to cover specifically things like oxygen and antimicrobials. And it does include things such as steroids. But the specific guidance on using things like bronchodilators, it does not cover at this time.
Right. So for the next question, there are some news circulating in social media regarding the pathophysiology of the virus and the use of a hyperbaric chamber or extracorporeal membrane oxygenation, ECMO, in patients who are in severe cases. What is your stand on it?
So currently, WHO does not have a specific guidance on that. Either using hyperbaric oxygen or using what's known as ECMO, extracorporeal membrane oxygenation. Those are performed in specific facilities, and they're generally done for very specific reasons. Hyperbaric oxygen can be given for carbon monoxide poisoning, can be given for patients that have some kind of diving type injury. The ECMO is done for patients that have very, very bad hypoxia. So we call it refractory hypoxemia or severe ARDS. Those are done in only specialized institutions. There's no specific guidance on that right now. I know that several locations that are able to do that have done it in some of these cases. However, there's no specific guidance at the present time.
Right. So Virginia Valenzuela just wants to say thank you very much for this very informative lecture. God bless you all. And then Catherine Repertoso is also saying thank you for the lecture, but she has a question. I want to confirm if in pediatric patients, we should also aim for SpO2 of more than 90%. Can you please confirm?
That's correct. So in all patients, keep the oxygen saturation above 90%. Again, if they are critically ill, which means they exhibit any of those airway, breathing, circulation disability, or organ failure, then above 94%. That's for adults and children.
Right. So at this point, just to, there's another question. All right, I was waiting for more questions. So for those with COPD, do we still aim to reach only 88 to 92% of O2 saturation? What if they are critically ill?
So that's a very good question. The guidance still says keep all patients above 90%, specifically for patients that are getting ventilated with specific types of techniques, you can go down to 88%. 88 to 92% will be the goal. But those are when you're doing ventilation, specific ventilation techniques. And the guidance does not speak to what you do with patients with chronic COPD problems and chronically hypoxic. It does not speak to that. There are other guidances that do, however.
Can I add to that? So yeah, if a patient has COPD, aiming for 90% still seems reasonable because it's within the 88 to 92 region. If you are aware that a patient has COPD, you have to be more careful. You need to be monitoring them more closely. They are a patient that you may consider having had them on oxygen for, say, over 10 minutes and their oxygen levels are stable, performing an arterial blood gas to see whether their pH is lowering or their PCO2 is going up, suggestive of carbon dioxide retention. So you just have to take case by case and make sure that you are still individualizing care whilst having these overall guidances.
Right. So the next question, Angelo Ramos is asking over the YouTube channel, is there any value for doing SpO2 determination of dyspneic cases for screening of COVID-19 at the primary care or community level?
So, James, you want to? So the answer to that is yes.
Yeah, well, I think so. Yeah, I mean, in the triage the triage algorithm that was developed, I know that there was an SpO2 measurement, and so I think that is a possibility to, part of it is to triage where you might send someone with suspected COVID, and whether they go to a community facility or a level 2 or level 3 facility. So there's definitely something there. Beyond that, I'm not sure. Sophie or Gary, can you speak to that?
Yes,
Or
there
Albert,
is.
because you developed.
There are recommendations to use pulse oximetry, SpO2 monitors, including at triage points, because it's one of the criteria that you would look at to determine where the patient goes.
Right, so that's quite clear. So that's something interesting. Another question from Angeli Garcia over YouTube. There were reports on early autopsies done that found thick mucus plugs in the bronchioles. How can oxygenation help if we're finding that? Over.
So that's a good question. So if the patient has a lot of secretions, then they're not going to be able to get the oxygen down to the alveoli. So they will require some form of what we call bronchopulmonary toilet, try to clear out the material. They either have to clear it out themselves or we need to assist them. And then once again, I listed all the procedures that could be aerosol generating. The one I didn't list also includes suctioning. So suctioning is one of those things that you would do to try to clear out the secretions. And in some cases where you have a lot of secretions, you can generate a lot of aerosols by doing the suction procedure.
Right. From Samuel Ong, is there a particular subset of patients for which a trial of non-invasive positive pressure ventilation, or NIPPV, is warranted prior to intubation and mechanical ventilation? And if so, how long?
So that's a very good question. The guidance has certain caveats. So what it says is when you're considering what's known as non-invasive ventilation, which is either CPAP or what's called BiPAP or high flow oxygen, the patient should be awake, the patient should be cooperative, and the patient should be hemodynamically stable. That's for all those oxygen devices that we just I just mentioned. Specifically for the non-invasive ventilation, the guidance says that you can consider, or certain clinicians could consider them in very selected patients. Okay. In general, it's not recommended for use in what's known as ARDS patients. It is not recommended, but you can use it in selected patients. And that's what the guidance says. For high flow nasal cannula, for ARDS patients, you could consider the use, even in ARDS patients. But you need to monitor them very closely and watch for signs that they need intubation.
Right. So Andrea David is asking in a related question. So thank you so much for the lecture. In managing RDS, say inside the ICU, how important is early intubation? And do we prefer nitric oxide over epoprostenol as pulmonary vasodilators when managing RDS? Over.
So I'm going to speak to what the guidance says. Okay, that's the guidance doesn't say specifically whether or not to do early or delayed intubation. I know that's becoming a major point of clinical care for COVID-19 patients. The guidance speaks to only general requirements for intubation. That is a very important issue that's coming up. Do you do intubation early as soon as the patient has any signs of respiratory failure, or do you delay and try to do things like high flow nasal oxygen or non-invasive ventilation? There's no specific recommendation on when you would intubate, whether early or delayed. What the guidance does say is that you should monitor them very closely, and if it looks like they're failing, then you should probably go forward with intubation.
Right. So this one is somewhat related question to the matter of aerosolization. Could you comment on the acrylic boxes currently being designed for intubation purposes, supposedly to decrease exposure of healthcare workers to infection risks doing the procedure?
So let me see if I understand that question correctly. I have seen some innovative products that have come out. The guidance is not going to speak to those specifically. So to recommend those, there's no specific innovative piece of equipment that the guidance is going to speak to. The boxes that I have seen is when you are intubating the patient and your arms and your hands are within a box and your face is outside of it. So you can intubate the patient without those aerosol generators. I have seen those. There's no specific recommendation. It looked like a pretty innovative and a good idea, however.
Right. So Virginia.
There was some discussion about that on one of the, I think one of the call last Tuesday night, I think they were doing it at Columbia University, where they have, I think the presenter was talking, they had 136 people in that hospital on a ventilator. And I think they were using that as one of their standard procedures. So yeah, I don't think there's any guidance on it yet, but I think it's starting to be used in out in the communities. Over.
All right, Virginia Valenzuela is asking, in follow-up to the COPD question, what is the safe range or low limit of O2 saturation in pediatric cardiac patients? Over.
So the guidance is not going to speak to a case such as that. The guidance is still going to say 90% is a lower limit. And for specific patients, I think the question is if they have some kind of a heart abnormality, or they're having some kind of intracardiac shunt or problem like that, whether or not you should target a different oxygen level. currently our guidance, which does cover adults and pediatrics, does not make any other distinction. 90% is the lower limit.
Great. This next question is a combination of both Boying Garcia's and Joseph Adriatico's questions. So, how effective is prone positioning or positioning COVID-19 patients on their stomachs such as, does it help bring more oxygen to the lungs?
So that's a good question. On Thursday, we're going to be going over respiratory failure and ARDS. That is one of the techniques that is recommended to consider when you have a patient with what's known as severe ARDS. There are 3 or 4 different techniques you could consider, such as giving them paralytics, doing things such as very high PEEP level, and then proning is also on that list. So the guidance does say that you can consider it in patients that have severe ARDS. In the toolkit, there is actually a checklist on how you go about doing prone positioning. And I highly recommend looking at that checklist for how to perform prone positioning.
Right, just a quick update. We have around 8 minutes left. There are 119 participants on Zoom and 196 on YouTube. This is a recurring webinar every 10 o'clock a.m. Manila time from Monday, that's today, until Friday, at least for the first run. So please do join us every time. Now, the next question from an anonymous attendee: to reduce aerosolization, are there standard equivalents for regular nebulization in the form of device inhaler puffs administered in intubated patients? So puffs versus open regular nebulization. What do you think, Gary and team?
So I'm not sure if I understand the question correctly. Is it the technique of giving a nebulized medication?
Right, right.
Okay. There is no specific recommendation on the technique of using a nebulized medication. What it does speak to is that in general, there are certain procedures that can be aerosol generating, and that does include administering nebulized medications or using some kind of high flow device, which you're using higher flow oxygen to deliver medications generally. The various techniques on how you do the nebulization, it doesn't speak to.
Right, so we have a few more minutes for questions. For those of us on Zoom, there is a Q&A feature. We are also monitoring the chat box, so you can use either function. For those of us on YouTube Live, we are looking at the live chat, and yeah, so Gaithesa Resurrection is just asking, will these materials still be available in YouTube after this session for future reference? I can answer that, yes. The YouTube recording will be available, and we will disseminate the link. I understand also, Gary, if I'm right, that the presentation slides will be disseminated shortly after the webinar. So anyone else with questions, please feel free to type it in. We can maximize 6 minutes, 5 minutes left before 11, don't worry. Or if our panelists or speakers have other comments on questions already discussed. Today's topic is oxygenation. Or maybe we can go to final words of advice. What do you think, Gary? Sophie, we haven't heard from you so much. If you have anything to add to the topic on oxygenation.
I would just say the guidance is broad and it tries to cover sort of all patients. So whilst the guidance is there, there will be differences in terms of practice within hospitals. So definitely have a look at the toolkit. It really is there to guide you. It's a very good way of taking a systematic approach to oxygenation. And if you manage to have a look at the other sections as well, I think it's well worth doing, especially ahead of the seminars and the webinars that will be coming up through the week. So do stay in contact, stay interactive, and yeah, make the most of these sessions. Over.
Right. And here's another question from Boying Garcia. How about the use of a portable oxygen generator? So what do you think of that?
So those are good, that's good equipment to have. Oxygen generators can produce up to 10 liters per minute of oxygen. So they cannot be used for patients that are going to be on non-rebreather, or if you're going to use a high flow oxygen system. But for patients that are going to require less than 10 liters, that's a very good system to use that doesn't require cylinders, nor liquid oxygen or some kind of oxygen plant.
And just to add, that sounds like something that can be used at the community level. I mean, we can always consider. So as a follow-up question, specialists advise the use of, the administration rather, of bronchodilators, SABAs, via multi-dose inhalers, the puffs, in lieu of nebulization to intubated patients. So this is a specific follow-up to our earlier discussion. What do you think on this?
So let me see if I understand the question correctly. Is it using a nebulizer versus a
metered dose inhaler? Yeah.
inhaler? Okay, yeah. So if you can, whichever way you can not open the circuit, which means that you're not disconnecting the patient, whichever way you can get the medication in without that risk of aerosolization, that's safer. The guidance is not going to speak specifically to which type of technique to use. However, it does list giving nebulized medications as one of the aerosol generating procedures, and using a meter dose inhaler is not going to be considered aerosol generating.
Still on the matter of bronchodilators, so Hazel Dokuyanan is asking, can you comment about the use of a tulobuterol patch compared with a metered dose inhaler?
So whether or not using a patch medication as opposed to some other kind of device that requires the patient to be administering it through their mouth, yeah, the guidance doesn't speak specifically. So if those medications were equal, you got equal efficacy for both, and one of them requires less manipulation around the mouth. I think that's what they're trying to get at, but the guidance is not going to speak specifically to using one of those over the other.
Yeah, I had a question just for Gary, just with nebulizers and how they lead to aerosolization. And is it because that you get a vigorous cough reflex following the administration of nebulizer, which you might not with MDI? See, this is non-ventilated patient.
So with a nebulizer, you're putting medication into a little receptacle, and what it does is it creates humidity and it creates an aerosol. And then the patient's breathing in and out with that, and those in that aerosol that's being created, you can potentially put in some of your own droplets, and that can spread to the rest of the room.
Okay, so that means that when they're breathing out after they've had this aerosolized, the virus could be aerosolized out, which would make me think that if you could use an MDI, I mean, if it's safer, right, that would. I mean, if it's as effective in some patients it isn't as nebulizer, then at least until there's guidance on it, that might be a practical suggestion until more guidance comes.
Right. I do think it's a very good question.
Right. So thank you so much. The time is now 11 o'clock, and we'd like to thank, on behalf of all the attendees and participants, we'd like to thank Doctors Gary Kuniyoshi, Sophie Dennis, and James Heffelfinger. Again, this is a daily webinar. The first series is this week, Monday to Friday, 10 o'clock Manila time to 11 o'clock. It was accessible via Zoom. Those who have registered, we are giving priority for the Zoom link to the first 500, but not to worry, as you can see today, we are also using a YouTube Live. The YouTube link will be left on. I mean, it's not going to be live, but it will be archived, so you can refer to it later. And you can also check the emails that we sent. There are links to the resources. The syllabus is also there, so the daily topics. We are seeing, for example, Regs Diag, thank you for asking about PPEs. So it might be for a different kind of webinar. We are focusing on clinical management, but that's a good thing. Very good question just now for administrative purposes. Is it the same Zoom link for the daily webinars? I think yes. In case it changes, we will notify you. But for those who got the Zoom link, it's probably the same. As for the YouTube link, it does change every day because of, I don't know how Zoom and YouTube are doing it. So we will update you with the new YouTube link every time it does change. So thank you so much. And on behalf of all of our panelists, we'd like to thank the attendees. Before signing out, there are 187 watching us on YouTube Live, 115 via Zoom. So any last final words, Gary, for today, Sophie and James?
Hope to see you tomorrow.
Right. Okay. So there's no need to register again. Those who have registered, we already have your email info in our database. So have a good morning and a good rest of the day, and see you again tomorrow, 10 o'clock Manila time. Bye.
Thanks, Albert.